Okay, so what I did not mention earlier that I want to mention now is that you will be practicing from a checklist when we first teach the skill. This is the checklist that your instructor is actually going to use as you perform the skill, and what I literally do is I check off and I make notes in the margins as to what I might want to correct or not. This was a practice session, and for a practice session, Ashley did an excellent job. There were only really a few comments that I wanted to make. So I noticed that when Ashley assessed the radial pulse, I like to landmark, especially when I'm teaching, that I'm literally going on the thumb side in the little groove here behind the bone. I wouldn't want anybody to think that they could put their hand like on the meaty part of the wrist. It literally needs to be in that indentation right there. And when you're counting it, you're listening to see if it's regular or irregular. That's really the goal of palpating it. How strong is it? Is it regular or irregular? So with that being said, when we're feeling the pulses in the feet, same thing. We're not really listening to doing the regular versus irregular. What we're doing in that point is saying, how strong are those pulses? Is the circulation that's coming from the head to the toe, or chest to the toe, really perfusing? And that could be the reason why she has necrotic toes, because she does not have a strong pulse. So the pulse can be different from one leg to the other. So, that's why you're always going to compare one side to the other, which Ashley did a great job of talking about. The other thing I wanted to just talk a little more about was about the edema, right? Edema means that there's swelling in the leg, and that is in the interstitial space. It's not in the blood vessel, and it's in the space between the blood vessel and the cells. So some patients have swelling that's hard, and some patients have swelling that's soft. So what you're going to do is you're going to palpate, and if the patient has edema, it feels much different than it does when it's a bony prominence. So we would squeeze it a little bit or touch it a little bit, and if it's pitting edema, it's going to leave an indentation. And if it's non-pitting edema, it's just going to feel like almost like the skin is going to break open. And sometimes it actually does break open because of the swelling. But you want to note that. You also want to note how high up it goes in the patient, because having edema in your foot is one thing. Having edema in your foot and ankle is another thing. But having edema that goes all the way up to your knee is a totally different thing. Sometimes there'll be swelling in one leg and not the other. That's very unusual. And you really need to investigate more what that's all about, because the patient could actually have a deep vein thrombosis in their calf back here, and that could be what's causing the edema in the one leg. So that's a different assessment for a different day. It's not part of a general head to toe, but I just wanted to just throw that out there. Another note that I made was, and I'm not sure, she may have talked about it, but I'm not sure, about when we looked in the eye, looking at the conjunctiva and the sclera. The conjunctiva should be pink and glistening. It's the part of the eye that's the mucous membrane. So on the mannequin, you can't really see it well, but sometimes you would actually pull it down a little bit and look inside, and you're looking, of course, for discharge on both sides. The sclera is the white part of the eye. It should be white. Some people have whiter sclera than others, but if you see a color like yellow or even like brown or bloody, that would be considered an abnormal finding. In the fundamentals course, we're really focusing more on the normal. So if you see something that isn't normal, you're really just noting that it's abnormal. You may not know the pathophysiology behind why that's happening, but we do just want you to be aware of that. When you're doing the ear assessment, you might want to inquire if the patient wears hearing aids, okay, or if they have any kind of a hearing problem. Because if you're talking to them, they could be smiling and nodding their head and not really hearing what you're saying. We went back and we did fremitus and excursion. That was good. Accessory muscles. So in the respiratory assessment, right, you want to think about accessory muscles. How much effort is the patient doing to breathe? Breathing is really effortless. It comes from our brain. It tells us our diaphragm to move up and down to help the lungs to expand. But when somebody's using accessory muscles, you see it. They're kind of like doing this, right? The shoulders are going up. That's an abnormal finding. The respiratory rate could be normal, could be between 12 and 20, but the accessory muscles, you should not see that. They also may have what we call nasal flaring, which is when the two nostrils, literally, think of like a the bullfight in Portugal, right, where it shows the bulls and their nasal passages are just kind of dilating open because they're going to run and they need to bring in that extra oxygen. That again would be considered an abnormal finding. Okay, so a couple notes over here. When you're doing the breath sounds, I find it to be the best to actually tell the patient what to do. Take a deep breath, and then move my stethoscope. Take a deep breath, and then move my stethoscope. When I move to if I do the respiratory assessment first and then I move to the cardiac, then sometimes the stethoscope will be in the front and I'll be like listening here to the mitral valve, and the patient will still be taking deep breaths. And I say to them, oh, no, I'm just listening to your heart now, so that they don't keep doing that, because that could be very distracting. It's also a good time to count your respirations when the patient doesn't know you're counting their respirations. You just leave your stethoscope on the chest, and it gives you the opportunity to do that. The thing about the valves, which we don't really talk about a lot, is that it's the 4 chambers of your heart, right? And so you are responsible to know where those valves are in terms of in the heart itself. So the aortic valve is pretty easy because it goes into the aorta. The aorta comes out of the left ventricle and is responsible for the oxygenated circulation to the rest of your body, right? The pulmonic, easy, going to the lungs, your pulmonary system, right? So the other 2 are the ones that could really trip you up a little bit. The mitral valve, which is between the left atrium and the left ventricle, is one of the most important valves of your heart, because if you have a problem with your mitral valve, that blood is going to backflow. And where does it backflow? Into your lungs, and that could be dangerous for you. And then the other one is the tricuspid valve, and that's, so if you know where the other 3 are, then you figure out where the tricuspid is. It's between the right atrium and the right ventricle. All right. What else we got? Vesicular, when we talk about breath sounds, vesicular just is kind of the periphery, right? It's kind of everywhere else. It's either in the main stem bronchus, under the right and left bronchi, or it's in the periphery. So those are like what we would call normal breath sounds. So we're focusing on normal. There are other kinds of breath sounds that you're going to hear in the clinical setting. We're not really going to be talking about them in the head-to-toe assessment. When you're listening to breath sounds and you're documenting them in the hospital setting, we're going to document them in terms of lobes. Now, taking anatomy and physiology, you learn that the left side of the chest has 2 lobes in the lung, the right side of the chest has 3. Reason being, your heart tilts a little bit towards the left. Remember, your heart's about as big as your fist, right? Tilts a little bit towards the left. So when you're documenting the breath sounds, you're going to document them by which lobe you're hearing them in. If you're listening here, that's the left upper lobe. It's the patient's left, not your left. Always remember that when you're looking at the patient, it's not your left, it's the patient with the patient's left side of their body. So we got left upper lobe, left lower lobe, right upper lobe, right middle lobe, right lower lobe, right? The reason I asked Ashley to not put her stethoscope in her ears was because I wanted her to be able to talk and hear any feedback that might be going on by her instructor while the instructor was sitting there. So normally, of course, when you do the auscultation for anything, you would have your stethoscope in your ears. So in part of the abdominal assessment, Ashley did both the inspection and the auscultation, but we also do palpation and percussion. So Ashley, would you like to just step in and demonstrate what that's about?
Okay. So when you're doing percussion, you're taking your 2 fingers and then you're tapping your other 2 fingers onto your middle finger. And then palpating, same thing, in the right lower first. Making sure the patient has no tenderness. Right upper, left upper, and left lower. You're just pressing in a little bit, making sure there's no masses, and the patient has no pain.
Thank you, Ashley. Okay, so again, in a practice session, your instructor will teach you about that. Percussion is not something you would actually see a regular bedside nurse do every day. You may see a physician or a healthcare provider come in and do it if they're, say, a gastroenterologist and they're doing a very focused assessment of the abdomen. So we have a general assessment and then we have a focused assessment, right? The focused assessment always has a lot more detail to it. So in your head to toe assessment, you're doing focused assessment really on every body part. But the purpose of percussion is you're identifying in the abdomen where there's hollow and where there's solid in terms of organs versus space, right? So when you're tapping over an organ, it's going to be dull because there's something solid there. If you're tapping over just the abdomen itself, you're going to hear what's called tympanic, which is it's kind of empty. So, and then palpating, as Ashley said, we're looking for abdominal masses and also pain. You should be able to touch an abdomen and not have the patient be like, in pain. Even for a post-op patient, even if for a patient that had post-op abdominal surgery, you are still going to palpate that abdomen because you want it to be soft and give a little bit. You don't ever want it to be hard or board-like. All right, so now just finishing up, as far as the urinary assessment goes, males, you also are checking for discharge from the penis as well, as females from the female genitalia. You have to pay particular attention if the patient is circumcised or not, because when you're doing cleaning, you have to retract the foreskin, clean underneath it very gently, and then rinse it, and then pull the foreskin back down. If you don't do that, the patient could actually get an infection there. Also, if you don't return the foreskin to its natural position, the patient can actually have the blood circulation cut off to the tip of the penis, and that could be very dangerous for them. So that I just wanted to mention that. And then when we talked about seeing if the patient has retained urine, right? So you should never, ever, ever be able to palpate the bladder because it's small. It doesn't hold a lot of urine. So you find the pubic bone, you're going right above the pubic bone, and you're just kind of touching, right? If you suspect that the patient is retaining urine, I think the word Ashley used was Doppler, and it's really a bladder scanner, which is more like an ultrasound. And she did say that, but I just wanted to correct that it's not a Doppler. A Doppler is a stethoscope that amplifies. So we use a Doppler sometimes if we can't palpate the pulses in the feet, we will use a Doppler which has a probe on the end of it, and we apply a jelly, and then we touch it with the probe, and then you can literally hear, lub dub, right? So similar to that is the bladder scanner. We would put jelly on the abdomen, use a different kind of probe, move it over the lower abdomen, the pelvic area, and it could actually estimate if there's urine in there, anywhere from 0 mLs to 1,500 mLs. So that would be the difference for that. The very, very, very last thing, and then we are done, is we want to make sure that everything is left in a safe way when we leave the room. Make sure the patient's call bell is in reach. Make sure that you tell the patient if they need anything to please don't hesitate to use the call bell. Make sure the bed is in the lowest position possible, and at least, in this case, 1 or 2 side rails is up. We always leave at least 1 side rail up because this is like a twin bed. And most people don't sleep in a twin bed, so we don't want them rolling over and falling out of the bed. So it is acceptable practice to leave 1 side rail up.